time once again for Community Forum, and we are very lucky to have with us live in the studios this morning, Sara. Sara is with the Yes on I-1600 Universal Healthcare for Washington State, and she is the Vice Chair of the Initiative Writing Committee. So we're going to be obviously talking about healthcare in Washington and the prospects for some changes there. Sara, thank you very much for coming in and spending time with us this morning.
Thank you very much for having me. It's great to be here.
So tell us, how did you get involved with this issue?
Yeah, so I think many people, was rattled by the 2016 election. And, I've always been opinionated, but I've never been political per se. I voted, and that was pretty much as much as I thought I had time for, having 3 kids and a full-time job. But after this 2016 election, I was like, okay, I need to get involved and do more. So I read Our Revolution by Bernie Sanders, and his message was a lot about grassroots involvement and getting involved locally to really change our culture and our society. And I went to a League of Women's Voters conference to get some advice from them and just kind of learn about civic engagement and how to get involved. And one of their big pieces of advice was to find 1 or 2 issues that you really care about or that you know about, and find who's already working on those issues. Don't start from scratch. You don't have to. To get involved, there's someone working on virtually every issue. And, we all care about a lot of things, but choosing 1 or 2 is the way to feel most effective. If you try too much, you won't be effective. So because I work in healthcare, I wanted to see what was going on in Washington. And through looking online, I found the organization I now help with is Whole Washington. So we're an all-volunteer grassroots organization. They formed about 1.5 years ago, I think, with the initiative process in mind. So we have an initiative to the people out there gathering signatures right now to form a state-based healthcare trust, which is similar to how other countries, publicly fund their healthcare. So the initiative is based on a bill that's been in Olympia for decades. There have been people working on this issue, and this is another eye-opening experience for me, was watching some documentaries and reading up on, single-payer or universal healthcare, how other countries are doing it. And obviously I knew that in Canada your healthcare is paid for, but I never really gave it critical thought or thought we could bring it to this country, much less this state. But, in the last 1.5 years, I've been getting educated and involved about what's possible, and it's right in front of us. We just need to cross that finish line. So the bills have been in Olympia for, like I say, decades. They've been rewritten and improved upon. In the legislature last year in January, there were hearings in the House and the Senate for these bills, which is a sign of progress that they're willing to have hearings. So I went down and testified in Olympia, as did many others, to try to advocate for getting it out of committee and, out for a vote, which didn't happen. So there is increased public discourse and thinking about how do we change the way we pay for healthcare, just based on how crazy and expensive it's gotten, and inequitable. There's 500,000 people in Washington state that don't have any coverage, which is inexcusable given the wealth that we have in our state. And so the Initiative Writing Committee that I was a part of took these bills and added funding. The first thing that Whole Washington did was they raised money to hire an economist named Gerald Friedman, who's at the University of Massachusetts in Amherst, who's worked on federal and state level efforts, and he's been studying healthcare economics for his career for decades. And we hired him to study Washington state and figure out how can we add funding to the bills, because the bills that have been in Olympia most recently didn't have any funding attached. So he did a financial study that's posted on our website in its entirety, 50 pages or whatever it is, and there's an executive summary there as well. But in his analysis, he found that if we did one single trust to pay for all the healthcare expenses of Washington residents, we would save $9 billion a year. That's a big number. And the majority of that savings has to do with simplifying the system. Right now, healthcare providers are dealing with over 150 plans. Many of them are for-profit, but even if you ignore that aspect, just the complexity of seeing patients that might have any one of 150 plans to figure out what coverage do you have, what's covered under that plan, just that complexity would be simplified if there were a single state-based plan. I got off track, but so we added funding to the bills is how it's different. It's also different because it has a transition plan. So we put some thought into how do we go from something as complicated as it is now to a single system. So in our plan, it's optional for employers to pay into it until 51% of Washington residents enroll. And then the payroll assessment or the tax would be applied to all employers in the state. Yeah.
And what would be that payroll tax?
Yep. So there's 4 funding sources that would pay into the trust. One of them, the majority of the funding, 65% of the trust would be funded by a payroll tax, which is set at 8.5% that employers would pay. And that is actually less than half than the average 18% that employers are paying now if they provide health care. So it would save big business a lot. So this would not only be saving residents, it would be saving businesses as well. And on our website, we have a savings estimator that people can log in and enter their own healthcare costs and their income level and their household size and those specifics about their situation to see if this legislation would save them money or not. It's predicted that over 90% of Washington residents would save. So employers, like I said, would be saving as well. So the payroll tax is one part. Another part is a long-term capital gains tax, which is also 8.5%. And it exempts the first $15,000, and it doesn't apply to retirement income or farm income. So it's really focusing on the capital gains that are realized by investors outside of retirement accounts over $15,000 a year. So that really only impacts the top 5% of Washington earners. So that's an 8.5% tax. So that's a new tax for them. A 1% income tax. So the initiative writing committee really struggled with, do we really want to put in an income tax knowing that our state doesn't have one? 1%, I think, is a good number. There's also a lot of misinformation about whether or not that's within our state constitution. And the way we've designed it, it is, because it's the same percentage applied to all residents, 1%. And it exempts the first $15,000 as well. So in our state constitution, believe it or not, there is a number, which is $15,000 is the maximum exemption from any tax. So that's how it's applied. It's 1% for all residents after the first $15,000. So that's one of the 4 sources. The other 2 I've mentioned, and the last one is a monthly premium. So it only applies to residents that are over 200% of the federal poverty line. So low-income people don't have any premium. It doesn't apply to children. And the initiative sets the maximum at $200 a month. I mentioned the $9 billion savings. That's based on Gerald Friedman's study. And in his study, the monthly premium he used was $134 a month, which is a funny number, but it's the same as the Part B premium that Medicare recipients are paying. So it essentially is Medicare for all is one way that people describe this. So regular citizens, non-seniors would be able to pay $134 a month into the state-based plan to get comprehensive benefits, including medical, dental, vision, prescriptions, mental health, just everything that's medically necessary would be covered under this plan. Yeah.
So what about co-pays for people that are participating in the plan?
There would be no co-pays, no deductibles. The only out-of-pocket costs would be on certain prescription medications if you're using a brand name drug when a generic is available for a non-preventative condition. So that's, a small percentage of prescription drugs are in that category, especially if there's a generic available. So we really try to encourage generic use. But if for some reason you or your doctor choose to use a brand name drug when a generic is available for a non-preventative condition, the copay maximum is $250 a year per person. So that came out of the Bernie Sanders legislation in the federal bill that he's written. So the maximum amount out of pocket is $250 a year, which we feel is pretty affordable relative to what people are paying now for their prescriptions. And everything else would have no copay in the prescription category. So there really is no out-of-pocket cost. That's the only out-of-pocket cost is that $250 maximum per year on certain prescriptions. And everything else is funded through the trust and those 4 revenue sources that I mentioned. It covers all Washington residents. Like I said, there's 500,000 people right now that don't have any coverage. There's also people that have very expensive coverage or inadequate coverage. The insurance commissioner a couple weeks ago for the state of Washington announced that he received the plans for 2019, and the average increase in the marketplace plans is 19% for next year. So the costs just keep going up, and there don't appear to be any controls. Not to mention that there are certain people that are uninsured completely. The Trump administration is now taking some of the Affordable Care Act to court, including the pre-existing condition protections. So it may be the case in the future that pre-existing conditions are no longer protected. And even right now, while they're required to cover people with pre-existing conditions, they might be more expensive. So just all the inequities in the current system are mind-boggling. But this plan, would not discriminate based on who you are or what your medical status is. As long as you're a resident of Washington, you would get comprehensive coverage under this plan.
So, assuming that what pieces of the Affordable Care Act were to remain intact, then this would would work well with that, would play well together?
The Affordable Care Act essentially, and I'm no expert, believe me, but it requires people to have insurance. And the premise was that if everyone has insurance, the risk pool will become larger. There will be more healthy people in the insurance pool. And so the cost of insurance should go down. I don't know that that's happened. There's been a lot of market drivers that are, over my pay grade, but it's not working, especially with the number of plans that are out there and the complexity of it for people looking on the marketplace for plans. It's confusing and hard to figure out, what should I buy? What do I need? There's networks right now, so certain providers aren't in the network that you might be enrolled in, and you wouldn't even really know that until you hurt your foot. Now you need a podiatrist, and that's how you learn there's no podiatrist in your network. I mean, the stories we're hearing about not having providers in their network, or there's only one and it's 60 miles away, or it's just completely impractical. A state plan like this would take away those issues because all providers in the state would accept this insurance plan. So it would really take away the Medicaid discrimination that you might see, where certain providers say they can't afford the Medicaid reimbursement rates for low-income residents. The state plan would really level set everything so that all providers getting reimbursed at the same adequate levels from the state. So I mentioned, it's a state plan. There's a board of directors that would oversee the plan, define the benefits package, but there's also 3 advisory committees that are formed under the initiative. And this was all taken from the bill. This isn't anything that we invented. It's just taken out of the legislature into a people's initiative. But one of the advisory committees is a providers advisory committee, so that physicians themselves have some input into the system and how it's working. There's also in the plan opportunity for small providers to have global budget negotiation with the state so that they could set their reimbursement rates on a global annual basis instead of per patient. If they have low volume, in small towns or in seasonal vacation areas, there might be sporadic patient volumes that make it hard to stay open. But part of the intention here is to make medical services consistently available throughout the state, no matter where you live. So Provider Advisory Committee will hopefully help make sure that providers are reimbursed adequately. And the providers that we talk to, it's a little bit of the echo chamber because they're excited and talking to us, but they're excited about the prospect of having essentially one plan to deal with. There would still be Medicare. I'll talk about that in a second, but it would be so much simpler than what they're dealing with now, like I mentioned before, with over 150 plans. So there's the Provider Advisory Committee. There's also the Citizens Advisory Committee, which would really speak to the customer service aspect of, our residents getting what we want them to get out of the system. And that would be the avenue for complaints or, concerns about the system. And the third advisory committee is a financial advisory committee that really makes sure that the trust remains solvent and that the funding levels are adequate to deliver the services that are needed in this state.
Okay. And Medicare?
Yep. So we get a lot of questions about Medicare and how that would work. So Medicare is a federal plan. We don't have the authority or really the desire to change that in any way. So seniors would still enroll in their Medicare and receive that as their primary coverage. The state plan would be their secondary coverage. So it's similar to how Advantage plans work currently. And me not being a senior, I haven't experienced this personally, but I've learned a lot about it, where Medicare by itself isn't enough. You usually need a supplemental plan in addition. So the state plan would essentially be that secondary coverage. We also have it written in to refund the Medicare premiums for people that are under that 200% federal poverty line. Under the initiative, that would be required so that those people aren't paying into the federal system anymore. They're getting their $134 paid to the feds refunded, because under the state plan, they wouldn't have to pay any premium. But we also have the Friedman study that I keep referring to, that assumes that all seniors would get their Part B premiums refunded by the state trust. So another thing that you might hear about is the notion of federal waivers. Congresswoman Jayapal is working on improving. She has a bill that she recently introduced, or is planning to introduce to the federal Congress, to make it easier for state-based plans to operate. So there's some concern that we won't have the ability to get, quote, waivers for federal revenue for Medicare to bring it into our state to spend how we want on a state-based plan. So we are aware of that concern, and in our initiative, we don't require the waiver to operate. Like I said, we would just residents would still pay into their federal Medicare, and then the state plan would be secondary to that, and they would pay into the state plan separately. So that's how it would work if we didn't get waivers. And in the initiative, we do ask the governor to seek federal waivers. So we recognize that it would be easier to have one system instead of seniors paying into both the federal and the state plans. And so if we do get waivers, then we could integrate. So you wouldn't have that pay into the federal plan, but have the state refund your premiums. But in general, the seniors we talk to are very excited about the idea of not having any Part D premiums. Their Part Bs might be refunded. So seniors especially would be saving a lot under the system. And again, if you go to the website on the savings estimator, you can really enter your specific scenarios to see if that's the case for you, especially with prescription drugs. I think there's a lot of people paying a lot out of pocket for prescriptions that would go away.
So philosophically, your campaign, I-1600, is taking the approach of doing this for Washington State. There seem to be a lot of people allied for wanting to bring healthcare to everyone that think it should happen at a federal level. What was your campaign's thinking on this?
Right. We would love that too. And we feel like it's a both and approach. It doesn't have to be mutually exclusive. Of course, we can still advocate for federal legislation. And I think it's obvious in the current administration that that's not likely to go anywhere, but we can certainly continue to advocate for that at the federal level. But I also think, as with many issues like gay marriage and marijuana, it oftentimes takes states to prove that systems can work in something so complex as this. And the two examples I gave are not as complex, obviously. But in Canada, that's how it worked. Saskatchewan was the first province to do it, and then it went national. Andy Slavitt used to be the head of Medicaid under the Obama administration. He's formed a new organization called the US of Care, which is a think tank that's really looking at healthcare policy and trying to figure out what the best system is. And when he heard about us and spoke to us about our approach, he was really pleased that there might be a state that can get this started so that there can be what's called a CBO score, a Congressional Budget Office score, that can really look at how the system operates on a state level and try to figure out how it can be expanded federally. That's actually how Obamacare started. It was started in Massachusetts under Mitt Romney. It was coined Romney Care at the time. But it's not uncommon for things like this to start at the state level to really do a proof of concept to show that, yes, it can work with the complexity of our healthcare system, and then make it go federal. So our intention is to bring this to every state. We would never want to create a great system at the state level only, but we believe it's the first step.
And the reason you're choosing the citizen initiative concept is because basically this has been something similar to this has been sitting in the legislature for a long time.
Yes. So there have been, quote, single payer bills in the legislature since, sometime in the 90s, and they're reintroduced, but they just never go anywhere. The farthest they've gone is getting hearings, much less votes in each chamber. And, the complexity of passing legislation is time consuming. We've seen it with education funding and McCleary and how it can get bogged down in politics. And it would take a lot of political will for a group of politicians to get on board with this. And there is a strong lobby force that's against it. The insurance industry and, the profit making in healthcare has a lot of anxiety about doing this. And in other states, the California legislature passed it twice when they had a Republican governor that wouldn't sign it. And when they had a progressive governor that would sign it, it suddenly stopped passing the legislature. In Vermont, it passed the legislature and the governor didn't sign it at the last minute because he was up for re-election and a small business lobbyist came out against him and insurance lobby. And I feel like politicians don't really feel that pressure until it really gets close, and then that scares them out of implementing it. But I think an effort like this would take that pressure off of the politicians and show that the people truly want this. We've been around the world. We recognize that it's cheaper and more cost effective, and our outcomes are very low. If you look at healthcare life expectancy and mortality, birth mortality, and all these infant mortality and all these, cancer survival rates, heart attack, morbidity, all of these things, these metrics, we're performing very poorly relative to our peer nations. And a lot of that has to do with people not being covered. The analogy I give when I'm thinking about the system and the struggles that we're having, reaching consensus and how complicated it is, I think perfection is the enemy of the good sometimes. And even people who are allied with this, they have a lot of anxiety and concerns about massive change. And they come up with these examples of, well, what about this? And these consequences. I think people are forgetting how bad it is now and how there are literally people dying When I started this campaign work, a friend told me about her friend who last November, 40-year-old in Lake Stevens, working guy, started to, have a respiratory illness, feel sick, virus, didn't have insurance, didn't feel like he could go to the doctor. He was getting worse and worse, getting more sluggish. His girlfriend finally convinced him to go to the doctor after work one day. And that was the day that he dropped at a coffee stand, ended up on life support, ended up dying from septic pneumonia, 40 years old. And really all he needed was an antibiotic, which would have, cost $10. Instead, his family got this horrible albatross of medical bills, and they lost him. That was completely unnecessary in a 40-year-old guy that dies. And that's one story of many in our state. Part of what Gerald Friedman did was study the life expectancy by county in our state. And in counties where health insurance coverage is lower, so is life expectancy. It's well understood by academics that people are dying because they don't have access to insurance. So the analogy I give is, we're in a blizzard. And like I've said, the insurance commissioner says it's only going to get worse. The forecast is bad. It's cold out there. But people who have insurance, they're dressed warmly. They don't recognize that it's cold and they don't see it or feel it. But there are people out there buck naked and there are people in tank tops and there are people who are really struggling. And what we're trying to do is build shelter, make it a 4-star hotel. The medical system will be intact. It will be privately owned and operated. There's misnomers about government-run healthcare. We're not going to government run the healthcare. We're going to government fund the healthcare. So we're trying to build this 4-star hotel where everybody can come inside when they need to. And some people say, no, you should wait until you have the 5-star hotel, or it should be truly single payer. It should be federal, or, the people that say they want it, they have critiques about why this isn't good enough. But I think it is good enough relative to what we're experiencing, and it would provide relief for a lot of people, including, maybe not even the uninsured, but just the middle class who they're not taking vacations because they don't have that cash flow because their prescription bills are so high or their medical costs are out of control, or the small businesses that can't predict how much it's going to cost them to insure their employees, or they're not insuring their employees because it's so expensive. But this legislation would really make it a fixed cost for businesses, 8.5%, truly predictable. Same with residents. They wouldn't have the unexpected out-of-pocket costs. I mean, can you imagine going to a hospital or being diagnosed with cancer and not having to worry about the financial aspect? I mean, it would truly be liberating for people to not have healthcare costs when they get sick.
Well, and isn't unexpected or even expected healthcare costs the leading contributor to bankruptcy currently?
Yep, absolutely. It is the number 1 or 2 cause of medical debt is the number 1 or 2 cause of bankruptcy, depending on which survey or which year you look at. But there's no doubt that medical debt is crushing people. And that's the proxy for the worst. But I think even below bankruptcy, there are people who are financially struggling and they don't have the disposable income. So I think it would help other areas of the economy. The economy would improve when people have predictable healthcare costs, more cash flow in their day-to-day lives. And of course, health would improve because people would get preventative services, including mental illness would be available for everybody, mental health care. So there's a lot of public health issues that could be relieved with a system like this.
Well, I didn't have coverage prior to the ACA. And I was jazzed to get that, although I have a couple friends who have found it to be more expensive.
Right.
But I have serious dental needs that I can't get met currently, with our current system, which is crazy. And it's when they have the event here at Seattle Center where they open up the arena for free dental. I mean, that is packed for 3 days. The people line up the day before to get into that.
Yeah, it's one of those things that if you have it, you don't really think about what it would be like to not have it, but it does impact a lot to not have dental care, and it can impact your general physical health as well, but obviously, cosmetics and stuff. So yeah, it's important.
So it sounds that a core part of your proposal is eliminating the insurance companies out of the equation. Is that true?
Yeah, there is a certain amount of job loss that would happen with the insurance industry, but also in doctors' offices with the financial processing. Gerald Friedman gave an analogy when he came through Washington State on his tour. He's from Boston, and a 700-bed hospital in Boston has, over 500 insurance processors. Same size hospital in Toronto has 2 in Canada. So if there's a centralized billing system where everyone knows where the bills are going, they're going to the state, they'll get reimbursed right away at a certain level, then you just don't need the back room of insurance processors. And it's not just hospitals that have that, but doctors' offices have, 3 or 4 financial counselors, they're called, or, you can talk to their financial billing people. So those jobs would go away. Many of them would just go to the newly formed state insurance company, state-funded insurance processors. But part of the initiative is worker retraining funding. So there has been thought put into retraining those workers, and there would be jobs created by more people seeking medical care. So providing medical care jobs would be created, but the billing and the insurance part would decrease.
But aren't the insurance companies the ones that are siphoning off the bulk of the money in this program? I mean, the providers obviously need a significant portion, but you've got these middlemen that are just basically, taking their share.
Yeah. If you look at what insurance executives make, it's in the tens or hundreds of millions of dollars. It's actually obscene how much money is being made in the insurance industry. And when you step back and look at it, what value are they adding? Like if they're narrowing your networks, they're still creating these high deductibles, high premiums. You have insurance, but then when you actually get admitted, you still have bills for hundreds or thousands of dollars if you have to be admitted to the hospital, or even just going to the doctor with copays and all that stuff. It adds up. So having insurance doesn't mean you don't have out-of-pocket costs.
Yeah, not to mention that they are the gatekeepers as to which medicines you can get. I have
it
multiple
drives doctors
friends
crazy. Yeah.
that need certain medicines to stay alive, and the insurance company will go, "Oh, we don't really think you need that one."
Right. Yeah, it's mind-boggling. Like I said, that they're the gatekeepers of medicine, which, who are they to say what's best for an individual patient? It should really be the provider and the patient making those choices.
All right. Well, we've just got about a minute left. We're talking with Sara So. She's with Yes on I-1600, Universal Healthcare for Washington State. And your organization has just a little over a week, maybe 2 weeks left in its signature gathering process. Can you quickly fill us in on that?
It is bananas. The deadline is July 6th, but of course we need the paperwork before then, so the sooner the better. We do have enough petitions in circulation to make the ballot, but we need them all turned in and signed. And we have about 75,000 signatures, and we need 260 valid signatures. They say you should really get about 300 because a certain number will be thrown out by, signature validation process. So please, 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 if you're interested in this, go to our website, Yes on 1600. We have a list of places to sign. We'll be all over Seattle this weekend, and in general at festivals and farmers markets. Gay Pride is a big event for us. We'll be in the parade. We'll be at Comic-Con today. We are really trying to find, any place where people might be out and willing to sign. Grocery stores. I'm sure you've seen the other signature gatherers out there. It's the season for that. The deadline is July 6th.
Is it too late to have one mailed to?
No, we're mailing until June 30th, and we will do everything we can to coordinate people with petitions. So just go to our website, and there are ways to get involved. You can order one by mail or.
And that website again?
Yeson1600.org.
All right. Well, with that, we are unfortunately out of time. I want to thank you very much for coming and spending time with us this
morning.
Thank
you very much. This has been great.